Hello everyone, I'm going to talk about the subject entitled Helicobacter pylori-uninfected gastric cancer. As you well know, Helicobacter pylori was identified by Dr. Warren and Dr. Marshall. It was reported that H. pylori is associated with various gastroduodenal diseases. 50 years have passed since its discovery. The IARC cites H. pylori as a group 1 carcinogen for gastric cancer. Recently, H. pylori infection rate is decreasing in Japan in any age. Accordingly, number of H. pylori associated cancer will decrease, while number of H. pylori uninfected gastric cancer will increase. Rate of H. pylori uninfected gastric cancer was reported to be 0.5% to 4%. So, we investigated endoscopic and clinical pathological findings of H. pylori uninfected gastric cancer in our hospital. Consecutive cases with H. pylori uninfected gastric cancers which were resected endoscopically or surgically in a hospital between January 2013 and May 2020 were included in the analysis. Primary endpoint was prevalence and clinical findings of H. pylori uninfected cancer. Other endpoints were endoscopic and clinical pathological findings of H. pylori uninfected early gastric cancer. I am showing the result. The number of H. pylori uninfected gastric cancers was 43. The prevalence of H. pylori uninfected gastric cancer among all gastric cancer was 2.3%. In addition, the prevalence of H. pylori uninfected advanced gastric cancer was 0.1%. Regarding clinical pathological findings of H. pylori uninfected cancers, mean age was 60 years. There is no difference in gender. In macroscopic type, elevated type was common. Location tended to be upper and middle part of the stomach. Depth of invasion was mainly mucosa and submucosa. Lymphovascular invasion was detected only in 2 advanced gastric cancer. I'm going to show H. pylori uninfected advanced cancer at the gastric cardia. An advanced cancer of ulcerative expansive type is located at the gastric cardia. Both 2 advanced cancers were located at gastric cardia. Histopathological findings show well to poorly differentiated adenocarcinoma invading down to the subserosa. So now, I am going to talk about H. pylori uninfected early gastric cancer. This is quite an interesting topic. The number of early gastric cancer was 41. It's quite rare. So, we classified histological type first as differentiated type and undifferentiated type. In differentiated type, there are gastric phenotype and mixed, that is, gastric and intestinal phenotype. In differentiated type, very well differentiated adenocarcinoma with gastric phenotypes such as foveolar type, fundic gland type, and fundic mucosa type is common. All undifferentiated type is signet-ring cell carcinoma. Localization was different depending upon histological type. Differentiated carcinoma with gastric phenotype is located at fundic gland mucosa. Differentiated carcinoma with mixed phenotype is located at pyloric gland mucosa. All undifferentiated carcinoma is located at the border between funded gland and pyloric gland mucosa, that is incisura. Macroscopic type is also different depending upon the histological differentiation. Differentiated type tended to show elevated type, and undifferentiated type showed flat or depressed type. This is a summary illustration showing the localization and histological type of H. pylori uninfected early gastric cancer. In the funded gland mucosa, adenocarcinoma of funded gland type, very well differentiated adenocarcinoma of foveolar type, and polyposis-associated adenocarcinoma are common. Signet ring cell carcinoma is limited to the border between the funded gland and the pyloric gland mucosa. Well-differentiated adenocarcinoma of mixed phenotype is common in the pyloric gland mucosa. I would like to show some representative cases. First, very well differentiated adenocarcinoma of foveolar type, type 0DA, located at the funded gland mucosa. By conventional white light endoscopy, a pale, superficial elevated lesion is noted at the upper part of the gastric body. After the dye was sprayed, it is evident that this is a well-demarcated lesion with regular granular surface. When we observe this lesion with magnifying endoscopy with narrowband imaging, it shows clear demarcation line and irregular microvascular pattern plus irregular microsurface pattern, which meets the criteria of cancer. Histological findings of resected specimen by ESC shows very well differentiated adenocarcinoma, which is similar to foveolar epithelium. So I'm going to show another foveolar type. It is so-called raspberry-like appearance. By overview, a reddened polypoid lesion is present besides a funded gland polyp. By closer view, it shows raspberry-like appearance. After the dye was sprayed, the surface shows a granular pattern. Magnified endoscopic findings with NBI demonstrate irregular microvascular pattern plus irregular microsurface pattern with a demarcation line, which are compatible with early gastric cancer. Histological findings of ESD resected specimens show very well differentiated adenocarcinoma quite resemble foveolar epithelium. Again, this is very characteristic endoscopic findings of very well differentiated adenocarcinoma of foveolar type, showing so-called raspberry-like appearance. This is a newly identified gastric neoplasia by Japanese endoscopists. Next, very well differentiated adenocarcinoma of funded gland type. This lesion is also characterized very recently. At the gastric fundus, a pale, slightly elevated lesion accompanied with superficial vascular dilatation. After the dye was sprayed, it shows smooth surface. By magnified endoscopic findings with narrowband imaging, it only shows regular microvascular pattern plus regular microsurface pattern without a demarcation line. So, this type of lesion can't be diagnosed as cancer by magnifying endoscopy. Histological findings of ESD specimens show that the surface is covered with normal epithelium, but in the middle part of the mucosa, there is neoplastic tissue which mimics funded gland. Since the neoplasia is covered with normal epithelium, magnifying endoscopy is not useful for making a correct diagnosis. So please remember again, the conventional endoscopic finding of a pale superficial elevated lesion with vascular dilatation are only keys for detecting such lesions. Please remember these findings, and don't forget to take a biopsy and write a message to the pathologist that you are suspecting fundic gland type of adenocarcinoma. This type of neoplasia is reported by Japanese doctors. Next is also newly identified neoplasia recently. This is called adenocarcinoma of fundic mucosa type. At the gastric fundus, a pale, slightly elevated lesion accompanied with vascular dilatation is present. After the dye is sprayed, the surface shows a granular pattern. So this is really characteristic finding. Magnifying endoscopic findings with narrowband imaging show a distinct demarcation line, and inside the demarcation line, irregular microvascular pattern plus irregular microsurface pattern are evident. We can make a diagnosis of cancer according to VS classification system. Histopathological findings show that in addition to neoplastic tissue which mimics fundic gland, surface epithelium is composed of cancerous tissue which resembles foveolar epithelium. So this is defined as adenocarcinoma of fundic mucosa type. Since the surface epithelium is composed of cancerous tissue, we can make a correct diagnosis of cancer by magnifying endoscopy. This neoplasia was firstly reported by us. We also reported that these are differences in magnified endoscopic findings corresponding to histological architecture. Please understand the differences. And then I'm moving on to the subject of mixed phenotype, which is detected at the antrum of H. pylori uninfected stomach. I'm going to show a case. At the gastric antrum, multiple slightly depressed resined regions are present. Among them, this region is well demarcated. By the closer view, a pale, depressed region is surrounded by reddened mucosa. Chromoendoscopic findings show an irregular margin. Magnified endoscopic findings of NBI show irregular microvascular pattern plus irregular microsurface pattern with a demarcation line. Light blue crest is present at the edge of marginal crypt epithelium within the demarcation line. This slide shows a mapping of cancer's extent on the ESG specimen. The size of the cancer is 5 mm. I'm going to show histological findings of this section. In the black square, I am showing neoplastic part. In the green square, non-neoplasia. The neoplastic tissue demonstrates very low-grade structure and cellular atypia, which is compatible with very well differentiated adenocarcinoma. When we investigate the background mucosa very carefully, it's quite interesting. Intestinal metaplasia is present even in H. pylori uninfected stomach. The last, I am showing signet ring cell carcinoma. This type is located at the border area between gastric fundic and pyloric gland mucosa. Can you detect the region? This is it. A minute pale region is detected at the posterior wall of the gastric incisura. A closer view shows a well-demarcated flat pale region. dye spraying method does not enhance the morphology of this lesion. By magnifying endoscopy with narrowband imaging, there is no demarcation line, and both microvascular and microsurface patterns represent regular patterns. So, magnifying endoscopy is not useful for making a diagnosis of cancer. Histopathological finding of the resected specimen shows signature cell carcinoma of 02B type, which is limited to the mucosa. The size is only 2.5 mm. Since carcinomatous cells invade the middle part of the lamina propria mucosa without changing the surface epithelium and the subepithelial vessels, magnifying endoscopy cannot detect any specific changes for carcinoma. As I previously reported, since a flat pale lesion is one of the limitations of magnifying endoscopy, we need to take a biopsy for making a diagnosis instead of magnifying endoscopy. Again, I am showing the characteristic of early gastric cancer in H. pylori uninfected stomach. In the cardia, advanced cancers are present. In the fundic mucosa part, we need to detect elevated lesion of well-differentiated type. At the border, we need to detect flat pale lesion of signature cell carcinoma. In the pyloric gland mucosa, we should detect very subtle lesion of well-differentiated adenocarcinoma. If we are familiar with such characteristic findings depending upon the part of the stomach, we are able to detect early gastric cancer even in H. pylori uninfected stomach. In conclusion, H. pylori uninfected gastric cancer shows distinct characteristic clinical pathological findings depending upon the part of the stomach. Thank you for your kind attention.